Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to our webinar. This evening, we're going to be talking about myths and facts surrounding isotretinoin and acne vulgaris. Our speakers this evening are Dr. Charles Lind, who is Chief Medical Director at the Lind Institute of Dermatology and Lind Derm Research, as well as Associate Professor, University of Toronto, Department of Medicine. We also have Dr. John Kraft, who is dermatologist at the Lind Institute for Dermatology and Lind Derm Research, Port Arthur Health Center, and investigator at Probity Medical Research. We'd like to thank our supporter, Cypher, for making this educational event possible. We'd also like to thank Cypher for making several educational events and webinars possible throughout the last couple of years with guest speakers such as Dr. Jackie Rao, Dr. Lauren Schachner, as well as Dr. Andrew Alexis in Burning Out Acne, Expert Evening on Pearls, What's New in Adolescent Dermatology, and Treating Acne in Richly Pigmented Skin. Before we begin, we have a couple of logistic tips for you. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up, and if you could fill it out and send it back to us, we'd truly appreciate it. Finally, within 1 to 2 days of the webinar, a recording of this webinar will be sent to you, as well as an attendance certificate. Again, if you have any questions, please submit your questions in the question chat pane on the right-hand side of your screen. As a disclaimer, the opinions expressed in this presentation are that of the presenters. They do not necessarily reflect the opinions of Cypher Pharmaceuticals. So without further ado, I am going to pass the floor now virtually to Dr. Lind and Dr. Kraft.
Thank you very much, Roxanne. Great, and hope everybody learned something about this drug isotretinoin that we use every day, certainly as dermatologists, but a lot of family doctors use this particular drug also. So tonight we're going to talk about acne, and particularly we're going to talk about the moderate, severe, and acne. And what we're trying to do is prevent that scarring that you see in the far right photo. Scarring is a major sequelae from acne and can be quite devastating from a psychological point of view for many, many patients. The learning objectives for tonight is to learn the difference between common misconceptions regarding the treatment of acne with isotretinoin and fact, and to learn how to address the patient and parents' concerns regarding these potential misconceptions. Isotretinoin is the gold standard for treating acne. It's been around for almost 40 years in Canada. It's coming up for a big birthday, as they say. And I think it's one of the major developments in treatment of skin diseases over the last kind of 40 years or so. We've got a lot of new fantastic drugs, biologics, a number of new topicals and everything else. But certainly in the area of acne, this sort of turned the world upside down. I'm old enough to remember actually doing the clinical trials back in 1980, 81 in Vancouver regarding this drug, isotretinoin. Amazing thing. Prior to this, what did we have? We had sulfur. We had a thing where you put sulfur all over the face. It was called Velmix mask. It smelled terrible. You went into hiding because you were putting this on. We didn't have much for really bad acne. We had benzoyl peroxides. For the most part, these really super dried the skin, caused a lot of irritation. And we had long-term antibiotics such as minocycline and also doxycycline. So major thing, 1982 FDA approval, 1983 in Health Canada approval in Canada. And there was such a big backlog of all these patients that had really bad cystic acne and scarring that could be treated. Unfortunately, the drug kind of withered for about 10 years. People were kind of, quotation marks, afraid of it. It works so well, and it potentially causes such potential side effects. You know, over the last 40 years, we've learned that, whoa, those side effects are very manageable. They're mild for the most part, and we can get over them. And so, in fact, sometimes even mild acne with a scarring that's occurring, we're using this particular drug. So there still exists a number of myths and special considerations around this drug, and that's what we hope to go over in this presentation. So basically, Dr. Kraft and I are going to do a number of different kind of myths and facts. We're going to ask the first polling question, and we say, isotretinoin causes anxiety and depression in all patients, and the risk of suicidality increases with the use of this. Is this a myth or a fact? We're going to ask you to vote, and I'm going to pick on my esteemed colleague in a moment. It's a myth. Very good. Very few people say that it's a fact. So I'm going to pass it to my esteemed colleague here, Dr. Kraft. He's the one that I picked tonight to talk about this myth, and he's well knowledgeable. John uses, like I do, isotretinoin on a daily basis, probably even 10 times a day on busy days. And so we're very familiar with this drug, but I think it's good that we actually think about it. And you'll see one of these kind of myths or facts that we're going to talk about tonight, we're diabolically opposed to each other. And you can see which one. But in fact, it's a myth. So John, why don't you give a little talk about this?
Yeah, thanks, Chuck. That's absolutely true that this is a myth. I mean, maybe when it first came out, obviously there were many horror stories of anecdotal reports of suicide and depression, mood changes, and when you look at that in population level, you really just don't see a difference in suicide rates and depression rates to a significant degree when patients are taking isotretinoin compared to not taking it. And that's certainly something that I relay to my patients. And this is an observational study from the British Medical Journal, and they looked at almost 5,700 patients with severe acne, and they found 128 were hospitalized with a suicide attempt. They were observed before, during, and after receiving the isotretinoin, and they found that over the course of the treatment, there was some this risk of suicide remained kind of the same whether they were on it or not. And then with the suicide attempt history, they actually made the attempts to a lesser extent than those who made their initial attempts during or after treatment. So it's certainly, if they have a suicide attempt history, it should not prevent a patient from receiving isotretinoin for treatment of their acne. And that's, I look at that as well. I mean, this is a conversation have with my patients, that there are reports of the suicide, but certainly, actually, a lot of people feel better as their acne is treated, as they're getting improvement in their lesions. There's more predictability day to day. The lesions are less painful. They're going to have less scarring. So they actually can feel better about their skin by treating it. And certainly that's something that I like to tell my patients. Next slide. And this is another report. They looked over 20 years over all the psychiatric events related to isotretinoin, 1997 to 2017, and there was a number of psychiatric events. I mean, obviously, these are a lot of young patients, and psychiatric events are just common in general in this population. We see mental illness in so many of our patients with acne and without acne, of course. They found that these depression, anxiety, emotional lability were some of the more common events, and they often happened, like more than half of them occurred in adolescence, 10 to 19 years of age. And we all remember that time period is certainly a challenging time for many, and there's a very common incidence of different emotional changes that take place then. There was a number of completed suicides, and 78.8% were male. But you have to look at the incidence rate compared to the general population. And they actually found that the incidence rate in our patients on isotretinoin was less than the general population. And this is a figure that I often let patients know, or a fact rather that I let them know, that the incidence of going on the medication, you have the same risk, or actually even less than the general population. So that's really important to clarify, that this is not something that there's no causal evidence that isotretinoin is going to cause mood changes or suicide. So we can be very reassured by what's in the literature regarding suicide risk and isotretinoin. Next slide. There was another review. This is in the Journal American Academy of Dermatology, 2018. It was a systematic review, meta-analysis, and they looked at 31 different studies that met the inclusion criteria, and they found that the depression scores were not different in patients receiving isotretinoin than those receiving an alternative treatment. I would challenge, though, I would like to see the depression scores, of course, at the end of doing a course of isotretinoin, and I would wonder if there'd be some improvement there as the acne improves. The prevalence of depression after treatment with isotretinoin, yet there it is significantly decreased. So there is evidence that you will actually have better mood changes over the course of treatment rather than not. So this is so clinically. How do I address patient and parent concerns? What do I do for that? I always talk about it. You must. It's like with anything where there's a black box warning or where there's concern. You have to address the elephant in the room. You have to address this fear that they might have, or they might have heard some misconceptions, a myth. They might have heard the myths that are rampant on the internet these days. Misinformation, disinformation. And they might have heard about these things, and so you have to address it with the parent. I like to tell them that you may have heard that there are some reports of suicide and depression on the medication, but we don't have any evidence the medicine actually causes suicide or causes depression. So I try to normalize, let them know that there is not a greater risk. We don't have any evidence of causality. It is something that we monitor because of reports of it occurring on the medication. So we do it responsibly. I check in with their mood at each visit, ask them how they're feeling. Do they elicit any symptoms of depression? Any thoughts of suicidality? I check in with all that at each follow-up visit.
Yeah, Dr. Kraft, I completely agree with you. Unfortunately, it's gotten into the literature, it's common parlance, and everybody believes it. Negative things seem to rise higher than positive things. I quite agree with you. I think most of my patients feel so much better. Their mood is better on this drug at the end of the day. They are very depressed in the beginning, and you actually get rid of the depression by putting them on the drug. But you have to, as you said, address the elephant in the room. And I think the important thing is to document it also, to document that you had the discussion. Initially, again, early on, people were kind of worrying, oh, I don't want to use this. You know, people are a little bit depressed. They've got ADHD and everything else, or they're on an antidepressant. For the most part, if it's kind of mild depression and everything else, I address it and everything else. If it's much more severe, I do check with their psychiatrist. If they've had a suicide attempt to get the okay, then you have basically your psychiatrist also saying it's okay. You know, this came in the literature. There was actually, John, you may not remember, but there was actually a young fellow who was 18, and this is how it came about. He was a senator's son. He took his dad's plane, and he was trying to do a 9/11. He drove it into a tower in Miami and killed himself and wrecked the plane and everything else. And his dad says, oh, it's because he was on isotretinoin. In the end of that whole thing, the fellow had been prescribed isotretinoin, but he had never actually taken it. So the mere whiff of suggesting that you should be on that thing. So there were a lot of misconceptions and everything else. So I think the big thing for the audience is that this is something you have to address with the patient, mostly because it's kind of been in the literature, when in fact we have good literature now with surveillance and everything that suggests that it's totally a myth. All right.
Thanks, Chuck. That was excellent, excellent summary. I totally agree, and we're just so much more comfortable using the medication. I mean, we've been using it for more than 40 years, and I think that's also reassuring. I really like to let patients know how long we've been using it for.
Okay, so this is the second polling question about the second myth. Isotretinoin treatment increases the risk of inflammatory bowel disease. Is this a myth or a fact? Please vote. Okay, very good. We've got a very knowledgeable group out there. So again, a myth. And hopefully the ones in the green that thing, we can sort of get them over and understand this. And by the way, this is stuff that, you know, if for some reason you get a case of this, you're on very solid grounds now in terms of the literature in terms of this. So it's a myth, and you could have lots of literature that would follow up. So this came about, and guess what? I mean, the big thing is the association. Inflammatory bowel disease, the highest incidence of inflammatory bowel disease is basically at the age group that you're using isotretinoin. And it's a faulty association. This occurs in sort of 18, 19-year-olds, 16-year-olds, and same people are going on potentially isotretinoin. So we found that the risk of inflammatory bowel disease is extremely low, and it's only just slightly higher than controls. 2.5 cases per 100 or 10,000 are in the controls. Why make the association? Well, surveillance bias. That would be putting it up. So patients on isotretinoin being monitored more closely. Anything that is unusual, you're reporting it into the thing. And in fact, a number of papers suggest that it isn't at all related to isotretinoin, but more potentially related to the long-term uses of tetracyclines. And as everyone knows that we don't want to be using tetracyclines on a long-term basis. You change the gut flora, you change the skin flora, and we're getting increasingly away from long-term use of tetracyclines. And doxycycline is often used to treat it, and maybe a confounding factor in this association. So I think the important thing there, again, to address it, because people will have heard about it, that you know, this can cause inflammatory bowel disease, but putting it out and saying that it's now been figured out by many papers, this is a faulty association and it's not related to this at all. Now, if you have a patient that, in fact, just wait a minute, Ashley, but if you have a patient that has already inflammatory bowel disease, then most gastroenterologists don't want them to be on doxycycline or tetracycline. And I usually check with the gastroenterologist and say, listen, this guy has very bad cystic acne. I need to treat him. The evidence doesn't suggest that isotretinoin increases that risk at all. And I prefer to use isotretinoin over long-term tetracyclines. And guess what? The gastroenterologists say, yes, Dr. Lind, that is the better attack. So again, it's something that I think you want to document, that you had this discussion, that you maybe have checked with a gastroenterologist, and then you have proceeded. I do go slower in patients with inflammatory bowel disease if I'm treating them, just to make sure that I do not induce any diarrhea or upset stomach or anything. And again, making sure that they take it with a fatty meal is also important. John, do you have any other tips around inflammatory bowel disease, or do you handle it differently?
You know, I handle it this. I definitely though do handle it a bit differently, because it's not something that I mention to patients. I don't have evidence that it actually.
Yeah, I must admit, where I think I say there are rare side effects.
I actually causes. I don't mention, because I don't have evidence that it causes it. So I know I do not mention that IBD risk.
Okay.
The only time that comes up is if I have a patient who has IBD, or there's a strong family history of IBD. Then I address it at that time. But if the patient has no family history and does not have IBD, I do not mention that. And I really like the way that you ask the gastroenterologist their opinion, and you get their agreement that that's a reasonable choice for the patient. So I think that's great, is getting a good working relationship with your gastroenterology team, and making sure that they agree with your choice to start isotretinoin.
Yep, good. Okay, so myth number 3, if you would. Isotretinoin requires monthly in-person monitoring by the dermatologist. Is this a myth or a fact? Please vote. By the way, everybody, you can put things into the chat too. Okay, so some people think that it does require monthly in-person monitoring. Most people think this is somewhat of a myth.
Yeah, so I think the key here was how you interpreted the question. Did you interpret as monthly monitoring, it's just monthly monitoring in general, or did you catch the in-person part? Because nowadays, with a lot of our consults being done virtually, in-person is no longer needed. And especially with acne, especially when a patient is already stable on a therapy, then it's very, very reasonable to monitor them remotely. We'll monitor them virtually. You could do that by video conferencing or often telephone assessments. And even monthly is not even monthly virtually is not necessary. If they're doing monthly blood work, you've had an informed, proper discussion with them, and they've consented and they're understanding of the treatment, and to see them every 2 months is also reasonable. So you definitely don't need to do monthly check-ins. If you're changing doses, if you're trying to find a stable dose, then that could be something, you may have to see them a bit more often. But when things are stable, when they're not developing acne conglobata and they're not on prednisone as well, then to see them every couple months is fine. For labs, definitely it's very easy to review on EMR, and lab monitoring is something that I admit has changed over the past 10 years of my practice. Whereas initially I was doing more testing for like CBC, hematologic abnormalities, but the evidence does not suggest that isotretinoin causes any type of hematologic abnormalities to any significant degree. And I was finding many kind of incidentalomas, things on the blood work that were interesting and maybe helpful for the patient to know about, but not related to isotretinoin. Things like thalassemia traits and Gilbert's disease, elevated bilirubins, and nothing that was related to isotretinoin. So I've really simplified my lab monitoring more based on the evidence that there is a possibility of transaminitis, so I check for that, and certainly evidence of hypertriglyceridemia, and then subsequently pancreatitis. So I definitely check for that on a monthly basis. For men, I do it monthly for the first 4 months at least. If there's issues, then I'll follow it along. If there's no issues for men, then often I'll be comfortable without blood work after the initial 4 or 5 months. But for female patients, I'm always doing monthly blood work, including beta HCG, and that would be the serum beta HCG rather than a urine test for that. So no, definitely I'm doing that monthly for my female patients, and I think we're going to be talking about that a little bit more as well, pregnancy and isotretinoin. But definitely there is more flexibility now with how often you will see your isotretinoin patients, and if you have them on a stable dose, always. I think we're going to talk about the starting doses, but no, definitely you have some flexibility there. Dr. Lind, what do you think?
Yeah, no, I agree. This has changed over the time period. Previously, when it first came out in 1983, it was you had to see the patient every month. Much stricter in the United States also with their iPledge program and everything else. We're much more logical, I think, in Canada. A lot of things, including most of our politics. But yeah, the way I do it, and I think this is useful to be able to do the platform and talk to the patient and see how they're doing. It's kind of like a hand holding without having to have them come into the office. Usually men, I do kind of set it up the first time. I tend to start my dosing a little bit different sometimes than some people. Usually for most of them, it's 0.5 milligrams per kilogram, and I might stay with that. And again, 2 months is what I often give the script for. And then basically they have to check in, or I check in with them. I ask for every 2 months of blood monitoring with the males, and the females setting it up that the lab just again does it on a monthly basis, their beta HCG. And I agree with you. Serum is what you want to know, because you want to be able to catch that unwanted, potentially the pregnancy, and get this looked after. Different people do it differently. And must admit, I do it differently in a woman who is kind of like not necessarily going, yeah, I'm pretty good at taking my birth control pill, and I've got an IUD in it. I'm going to do the 2 things. Sometimes there's ones where the kind of red flag goes up and you've got a history that they've already had 2 abortions or something in their background, and you go, I want to check this person a little bit more carefully and monitor them a little bit more carefully. And that one I might be doing it on a monthly basis, actually seeing them and not giving them a further month, and then being able to check. Over the years, John, I've had people that basically you are the birth control pill. Yeah, I am. And then you cast them subsequently at month 2 or something. Oh, well, I went off the birth control pill because my boyfriend and I were not, we're just doing it once or twice a month. And yeah, that's not likely to get pregnant. And you go, whoa, you pull out your hair and say, no, we've gone over this and I'm not giving you any more isotretinoin until you comply with the measures around it. And touch wood, I've not had anybody that's gotten pregnant on the drug. So I think it's very important. And in this era that we're trying to save money, you don't need to be doing all the blood tests all the time, but it should be good to monitor them. And I think it's also, in case you do in any way get in trouble with the drug, you can say, well, yes, I did set out a plan to monitor it, and the patient was the one that didn't decide to go get the blood tests, etc. So a myth, you can do it much easier now than we could previously. Okay, next polling question. By the way, anybody has anything in the chat, please send it in and we'll address them at the end. Ashley, polling question. Okay, abstinence is the only safe form of contraception. Myth or fact? Okay, everybody's voted. Okay, so again, there's some people, I guess, you know, in terms of abstinence, yeah, I guess if you aren't having sex, it's kind of hard to have a virginal birth and everything else. But yeah, you don't have to have totally during this period that you're having people on 6 months of isotretinoin, you don't have to say just be abstinent. I think there are better ways of doing this with more birth control pills, IUDs, and everything else. Dr. Kraft, you're on for this one.
Thanks, Dr. Lind. So yeah, definitely, you know, this is a myth because the other forms of contraception are reasonable and effective. Obviously, abstinence is like real abstinence, like you're saying, Dr. Lind, that is the best, but you know, not able to for everybody. So 2 forms of contraception is definitely appropriate, and it is required if the patient is not abstinent. And I tell all my patients that. I say every patient, they have to have 2 forms of birth control if they can get pregnant. And the pregnancy test should be done in, I do it before starting the treatment, of course. I do not let them start the medication until they've talked to me and we've reviewed the blood work together. It does say, obviously, 2 pregnancy tests prior. This is where I go a little bit off label, where I will do 1 pregnancy test before starting the therapy. I am fine with that, and then I repeat monthly pregnancy tests throughout the entire time. And this is always something to think about, would be doing the final pregnancy test 30 days after the last dose, just to make sure there's no chance of pregnancy after stopping medicine. I generally tell patients that they should wait at least 2 months after stopping the medicine before it's safe to get pregnant, even though in the textbooks, the product monograph, it says only do one month. I like to have that additional window of safety, and really making sure that they maintain good contraception in that final month is important. And doing the blood work after stopping 30 days is another way to remind them that they should have been continuing with their pregnancy prevention during that month. And this is where patient education, very important. It's very easy on a busy day to say, hello there, young lady, this is I'm going to be giving you a medicine where you cannot get pregnant. What's wrong with that statement? I'm giving you a medicine where you cannot get pregnant.
Sounds like a birth control pill to me, John.
That's like, exactly right. So you know it, you're meaning it as you must not get pregnant on that medicine, but you tell that to a patient, you can't get pregnant. Oh, wow, I didn't know this functions as a birth control as well. So just be very careful. Don't use euphemisms. Really talk about the need for pregnancy termination or an abortion is highly recommended if they become pregnant after exposure to even several days of isotretinoin. There could be a risk there. So definitely really, sometimes we don't lay things on thick. We kind of gloss over, but this is one example where you really want to educate them very clearly that this is a real teratogen. This will cause severe, irreparable birth defects. Talk about limb malformations, brain and organ malformations. That really gets the patient's attention and really reminds them that this is serious. And they then come into line and realize that they are responsible for this prevention during the course of treatment. So definitely important counseling. In the US, as Dr. Lynn mentioned, we have the iPledge program. In Canada, we are doing it with documentation in our charts, and sometimes even signing additional consent forms as well. And a nice tip, always have the patient like, what do you understand from this? What will you be doing? What is your role, your responsibility while you're on isotretinoin? And they can give that back to you if they've been paying attention, and you can clarify where they might be a little bit off.
And one of the other things they address, John, as a teaching point, is when you hand out the brochure about isotretinoin to your patient to take home so they can further go over what you've already talked to them about. Certainly there's a great deal of that brochure that goes over about pregnancy prevention. People often think about this, that, oh, this is going to make me, quotation marks, sterile. I'm never going to be able to conceive and everything else. So I actually tell them that this is only while they're on this drug and for 1 month after. In reality, it's out of the system within the first week, but we tell them 1 cycle to just make sure things are fine. And I say, this doesn't prevent or have problems or subsequent when you get married or whatever else, that you're going to have any problems conceiving or that there's any risk subsequently. The other thing's equally so for a guy. He's reading all this about females and he's thinking, oh, well, it must have something to do with my sexuality here too. It doesn't. And they say, it does not in any way interfere with your sexuality in terms of this. So those are, I think, all important things. And like you said, John, you kind of tee it up with that very first consultation. When you spend more time with the first time and getting them on it, the subsequent visits, as we can say, can be done virtually, or it can be done a very quick, hi, how are you? Are you still taking your birth control pill? Having any side effects, anything that you need tuned up? And here's your next dose of drug, and we'll see you again in 2 months kind of deal. So education, as you said there, is extremely crucial. All right. So next polling question, number 5. All right, you're going to see here that my son-in-law and I have a little differing here. So transsexual patients do not require special considerations when treating with isotretinoin. Is this a myth or is this a fact? Votes, Ashley? Okay, a myth. Okay, and some people say it's a fact. So we will go on here. I think it's a myth. I think they do have to have special consideration. So transgender individuals obviously have an increased risk of negative health outcomes, depression, suicidalization, self-harm. There's a lot of complex things going on at the same time. This can be compounded with the baseline negative mental health outcomes from having just bad acne too. Remember, some of them may be on high dose testosterone, and that again is making their acne worse. Now, you have to kind of, like everything in medicine, you have to interact with your patient on a proper footing, and appropriate pronouns, and basically document how the person wants to be referred to. Do they want to be referred to as a he, a she, prefer not to answer, trans, etc. And again, you have to have these conversations regarding a patient's reproductive status and sexual orientation. Now, if you have a female and that is quotation mark switching to a male, that person potentially, even though they may have high dose testosterone floating around, I think can potentially still get pregnant. And you know, there are many different sexual mores, etc., and everything else. And they've still got a uterus. They're still potentially got those ovaries in there, and there may not be cycling, but there may be eggs sitting there somewhere. And I would certainly wouldn't want that person. You're going to hear a little different getting pregnant. You're going to hear a little different thing. So I do require that. That requires a lot of skill saying to the person, I recognize that you want to be referred to as a he or whatever. And that basically, but however, for me, feeling comfortable because you still have a uterus in there, unless that's all been looked after, that I just don't want to take any chance from my point of view of you potentially getting pregnant. So John, you had a little different thing on this. And obviously a male going to a female is not a problem because
No.
they can't get pregnant. But the female changing to a male,
Yeah. No, if they've
there's
already,
sensitivities.
yeah, no, if they've already changed and they identify as a male, no, I do not do beta HCG in people that identify as a male. I'm concerned that when they go to the lab, it's going to take them back. They're going to get those negative feelings of, but I'm not a woman. I'm a man. Why should I be doing that test? So,
Yeah.
no, I'm
Certainly,
comfortable.
good point, John. Certainly don't just tick it off on your slip and give it to them,
Yes.
whatever, and order it blindly. And they go, whoa, 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 why is Dr. Lynn ordering this test with having, so have the discussion, and some of us will have the discussion, like myself. My son-in-law here, Dr. Kraft, feels comfortable them, particularly I think if they're on high dose testosterone, the likelihood of that pregnancy occurring is very low, and he's happy with that. So again, I think this is something at least to consider, because you will have these patients in your practice, and unless you've kind of thought about it beforehand, you can really muddle it up. And I must admit, I've muddled it up a few times. It's a bit like, you know, the person that comes in that's had a baby a year ago, hasn't lost the tummy weight, and you go, you know, I can't give you the isotretinoin because you're pregnant. And the person says, oh, I had the baby a year ago. So many times I think all of us have made little muddles like that. But I think it's something to consider beforehand to know what you're doing.
Another challenging point, Dr. Lind, is that sometimes it takes, our health card system is kind of archaic or slow, so they have a new name, and the dead name is on their health card, and it's so easy to, when you walk into the room, to call them by their kind of dead name, if you will. And that is something that is a real no-no. You want to really get a sense, look at that referral carefully. The family doctor will often tell you, this is patient, you know, he's now no longer this, he now goes by this name, and look carefully for that and really try to be respectful. If the mistake happens, just acknowledge it, say, oh, I'm sorry, I saw that on your health card, I understand that that's no longer who you are, and go from there.
Yeah, so John, have you got any tricks about, you know, both of us, dermatologists in general, see lots of patients on any given day, and you may not have seen this person for 2 months. They're back in your office, and they look like a she still. They may have breasts or something, but they're going to be a male. It's very easy to make that mistake about the name. everything else. You got any tricks to alert yourself that you may not remember how you should be addressing that person?
Oh, no. I would only know that if I'm given warning in advance by seeing it on the referral from the family doctor. That's why it's really important if you're a family doctor and you're sending a patient who's undergoing transformation to really make that very clear as like the first line in the reason for referral. Like, just it's really let us acknowledge that so we don't so we can make it as smooth as possible for them when they come to see us.
Yeah, so one of the things is to put in your EMR for when that return visit occurs, that you in red letters or something, so that you recognize that there is a sensitivity here and you're approaching it from the correct how they would like to be called.
Yeah, that's the nice thing about our EMR is that regardless of the health card, what the health card says, we can edit the name of the patient, and we can put that in brackets and big bold letters. This is what the patient wants to be called, and that's what you say.
Okay, so we'll put up the next polling question. Okay, so there's a concept around isotretinoin being sun sensitive, photosensitive, photoprotected, can only be used in the winter months in Canada. And you shouldn't be using this in June, July, August in Canada. We've got nice, beautiful weather. It's hot out. There's lots of sun. People are going to be out swimming. So is this a myth or a fact? And please vote. Ah, boy, everybody got this one. So it is, in fact, a myth.
That's 100%. That's incredible.
Yeah, we did well, John.
That's fantastic. Wow. Because well, I think everybody knows like this is a year-round prescription for us. If we could only prescribe our acne patients isotretinoin once a year, oh, that would be a pretty challenging practice to organize, and you'd have a lot of very disappointed patients in the summer and spring months. So definitely a myth. Isotretinoin, this is a year-round drug. We can help our patients out at any time. We can help them out if they travel down south, if they move to a southern location. This is a medicine that can be used around the world. It just requires appropriate counseling. It's not a true sensitizer. Rather, it can mechanically potentially thin the stratum corneum, and that's why it can make someone a bit more sensitive to sunlight. You have patients that they go down south, they forget that you've talked about the importance of sun protection. They're like, oh yeah, Dr. Kraft may have mentioned to go extra careful when you go to the Dominican Republic this March break, and they go down there and they get terrible burns, and that's what you want to try to avoid. Really let them know, remember, we talked about this. This is something you have to protect yourself. You can't just go out with your buddies and kind of pass out and on the beach for a couple hours. No, you have to be careful. You have to wear protective clothing, hat, and sunscreen, SPF 50 or higher on all the exposed areas. And definitely remind them of that each time. Ask patients, are you going on any vacation? And really let them know that this medicine will make you more sensitive to burns. So definitely avoid tanning. These are just good rules in general, but especially on isotretinoin. And that's why you can use this medication year round. Even in the winter, you're at higher risk of burns when going outside in the snow. The snow is very reflective. If you're going to skiing or other outdoor sports, you can be at higher risk of burns as well. So they also require good sun protection in those settings too. So definitely a myth. We can use this year round. It just requires appropriate counseling and reminders for our patients. Dr. Lynch,
yeah, I agree. I when it doesn't make them sun allergic, it's sun sensitive because there is thinning of the stratum corneum and everything else. And I explained, this is used by dermatologists in Miami. It's used by dermatologists in Los Angeles, Las Vegas, where they get sun kind of 365 days of the year. But again, appropriate protection, which they should be doing anyway, but just being a little bit more meticulous about it. And I encourage people to actually continue using it if they're going for a week or two down to Florida and everything else, because I don't want the treatment to be interrupted at all. All right, got another one, number 7. So this should say all isotretinoin products are created equal. I don't know where the equal went off of that, but anyway,
Oh, no,
typo.
no, sorry, Dr. Lynn, I see the equal.
Oh, it's there. Okay, I just can't see it on the board. So is this a myth or a fact? You can use the older brand of isotretinoin, the Accutane. There's a generic form called the Claris, and there's a more modern form called the Puris. They're all isotretinoins. So are they all equal? Yeah, it's they're not created equal. And I'm going to give you a little bit of data around that. It's a myth again. So certainly isotretinoin needs to be better absorbed with fatty foods, yogurt, milk, cheese, eggs, meat, avocado can be used, a bit of peanut butter. Even make a joke when I'm telling people you can even take this with your Big Mac or your Whopper or anything else. And again, individualized dosing schedule are product dependent also is another sort of fact. So most dermatologists, I think, are using the newer type of isotretinoin, the Puris, because it has Lidose technology. And it's basically, isotretinoin is lipophilic, not totally well absorbed by itself. And if you give fat or you make a Lidose technology, you can increase that absorption. And so this is embedded. It improves the intestinal absorption in the absence of food with variability. And look at the population that you're normally dealing with this. You know, we are using it in kind of 30-year-olds and 35-year-olds. But for the major part of the things, these are kind of late teens, early 20s. They get up, they should be taking their medication. They have a glass of water. Maybe they have a glass of orange juice. They're off to school or off to work or whatever else. So to get around that and get better absorption and make sure it's working, this is certainly the better option. And this just basically shows you the bioequivalence. So if you have a high-fat meal, you take either one of these, the absorption is equivalent. However, in a fasted state, the absorption of a Puris, the isotretinoin with the Puris, is approximately 83% greater than the old Accutane. So better absorption gives you better results because you're getting more drug into the system to improve people. The other thing I think is individualized things. So it's nice to be able to have different dosing regimens. Sometimes people will want to start really slow, or you may as a physician want to start slow and gradually work it up, because sometimes people say, oh, you just talked about how it's going to make my skin sensitive, it's going to make it dry. I've already got dry skin. Fine, we'll start really slow. And I just explained to them, it's just going to take them longer to achieve the results that we want to achieve. And you can have different ones. And the Puris in particular has different ways to mix and match. They have 10s, 20s, 30s, and 40s. And you can mix and match and get the dosing that you particularly want to have. So, anything else around that, Dr. Kraft?
Yeah, Chuck, I just love the flexibility of the isotretinoin Lidose in the Puris. First of all, the fact that they can take it, I like to say, no matter what you're eating, it is effective. It will be absorbed even in the fasted state. So just gives you so much more flexibility when a lot of people really want to eat healthy nowadays. And the fact that it comes in different doses makes it a lot easier to customize the dose. Maybe I'll start with 20, maybe I'll start with 30. To do that with the other isotretinoin doses, to take 2 or 3, 10, just a little bit more cumbersome when it comes to patients keeping track of the pills. So it is easier just to have these specific doses. You can then do more interesting combinations more easily, 70 milligrams a day, 90 milligrams a day in heavier patients. So no, I would really like the flexibility and the customizability of the drug.
So, I think the take-home message is here. I hope we've left you with some kind of ideas of things that you can get that message. And, this is something that certainly dermatologists do kind of day in and day out. And I can do this spiel that I have for every one of my patients in my sleep. Maybe I do, actually. I haven't asked my wife that. But you do have to often address these misconceptions, because people are coming in and go, this is a drug that makes everybody sterile, increases the scarring, whatever, one of all these misconceptions that we were talking about, gives them inflammatory bowel disease, makes them suicidal and everything else. And it remains basically the gold standard. And why? Because it's highly, highly, highly effective. And in my career over the last 40 years, this is one of the drugs I would name as being one of the top 10 innovative things that's made our life and people so much better. And it's safe when it's used and monitored properly. We're giving you some ideas in terms of that. I think, Roxanne, you probably have got some chats that have come in from people, and maybe we have some more time for a few questions.
Yep. So again, if you have any questions, submit them in the question chat pane on the right-hand side of your screen. And if you think of anything after this webinar, you can always send the questions at info@RBC Consultants. Again, we would like to thank Cypher for supporting this educational event. So one of the questions is, how do you know when to stop?
I'll start with that one. And again, each of us, you put 10 dermatologists in the room, you probably have about 10 different ideas. Basically, I stop when I know that the patient is completely clear. You want to achieve that completely clear, and that may be different timelines. It isn't always like at 5 months or 6 months necessarily, particularly if you started slower. If you started slower, and then in the literature, they talk about 120 to 180 milligrams per kilogram over that time period. That's the magic sweet number. Being old enough and being there from the very beginning when these drugs were developed, that was a thing that was just completely pulled out of the hat. They figured that you really want to monitor the patient and see. And I like to be able to see that that patient really hasn't had any further acne for at least a month before I'm stopping it, so that I know that I've had clearance with it. John, have you got any things? When do you stop?
Yeah, absolutely, Chuck. So in residency, of course, we were always very strictly calculating. In part of your notes, you'd say, well, they've achieved 80 milligram per kilogram so far, and they're not at the magic 120 to 150 yet. So we got to keep going, and we're not really, you're looking at the patient, but you're looking at the numbers too. It's not a numbers game with isotretinoin. I mean, it is in a way. Like you ideally, like I agree with schools of thought where to have a higher dose is actually a little bit more effective than a lower dose in terms of maybe better chance of remission. Like to achieve at least 0.5 milligram per kilogram is better than just staying on like 0.1 of a milligram per kilogram at the beginning. Like just go, you want to get a certain high dosage, at least higher than 0.5 milligram, work up to that dosage. Fine. When you work up to that dosage, then I like to continue until they're all clear, and then they're clear for at least 2 months, no new outbreaks for a couple months. And then I can say, yes, I'm confident. I'll put you on a maintenance therapy now. I'll use a topical retinoid for maintenance, and that'll help maintain your clear and start to improve some of the remodeling of collagen, maybe improve some of the scars as well. And we've seen data from a lot of the topical retinoids that have shown improvement in scars. So definitely switching them to maintenance therapy after a couple months, and it ranges usually like 6 to 8 months. I often tell patients 6 to 8 months. Of course, there's going to be some outliers, but generally that's a good amount of time for most of my patients.
Yeah, this is again something that we learned around the world early on. Dr. Kraft, in Germany, basically they would start with the 1 milligram per kilogram for the first month, and then they would rapidly move to 2 milligrams per kilogram. And get her done. We're going to get this done in 3 months, 4 months. And they were able to clear people, but they had a whole lot of more side effects. People had more cheilitis, more dry nose, epistaxis, and dryness of the eyes and everything else. I think the tendency that we've learned over the last 40 years is to go lower and basically 0.5 milligrams per kilogram. I often start with that and move with that and don't increase it, and I just go longer. I just basically achieve my endpoint by they're clear and they stay clear. And there isn't a problem if you've got them clear and then you've used your maintenance with a topical retinoid as we talked about. If they need another course, there's no problem. You can go back and do this. And that's again another misconception. We didn't discuss that earlier, is that, oh, I can only have this once in my lifetime. That's all I can have. No, I've got patients that I've used isotretinoin 6 or 7 courses, and they come back and go, let's do it again, because that's the thing that works for me. I don't want to be on long-term oral antibiotics. I don't want to be putting creams on my face all the time and irritating it. So that's an important point also. Yeah, it's not a problem. It's a safe drug. Again, monitoring, making sure that the second time round that you'll go back and remind them, particularly a woman, you mustn't get pregnant on it. Remember, we talked about that the first course. The same thing applies the second course, and to go forward with that.
So some patients swear that isotretinoin use.
And Dr. Lynn, you can like.
Can you hear me?
Yep, John, you had something to say? John, you're muted, I think.
Yeah, Chuck, just sorry, Roxanne. Okay.
You're muted.
Yeah, sorry, I just,
Oh, I think Dr. Kraft is having some technical issues.
Okay.
Can I ask you a question from the audience,
Sure.
Dr. Lynn? So some patients swear that isotretinoin gave them permanently dry lips, even years to decades after cessation of treatment. Is there any merit to this?
No, I mean, it certainly does give them super dry lips. You can look after, one of the things I like is a product called Sticoplast. It's by La Roche-Posay. It's something that is very good for those dry lips. I have them use it during the course of their isotretinoin and afterwards if they need it. And it's just really, it's like anything, their patients will swear that it caused their skin to be permanently dry. It doesn't do that. It's not something, it goes out of your system very quickly. So certainly the dry lips and the overall dry skin isn't something you can blame on this.
Another question that we have from the audience, is there something magical about 100 milligram to kilogram?
No, I think we discussed that, Roxanne, that it's not necessarily, that was sort of like a statistical modeling on the population, that if you got to that dose, that was typically after 5 or 6 months, you got, most people would be clear, almost clear. They were, in the original studies, they were actually stopping people at that point, even though they might have some active lesions, thinking that they had, quotation marks, got the cure. In fact, we now know that go until you've got them clear and they maintain that clearance for at least a month.
Now, can you give more than one course to the same person in one lifetime?
Yeah, we talked about that sort of. Yes, absolutely. It's not a problem with it in terms of giving it more than once. And as I mentioned, I've had patients 5 or 6 times they've used it.
Any considerations for skin color?
Dr. Kraft, do you want to take that one?
Yeah, absolutely. So patients with the richly pigmented skin, they have higher chance of post-inflammatory pigmentary changes, and that can be a real burden for many of these patients. With the brown marks that get left behind after the acne, and those are very hard to treat. And it's a reason why sometimes I'll often do isotretinoin therapy sooner in these patients, even though they may have more moderate acne, just to help prevent further lesions from causing more pigmentary changes, which are very hard to treat. We have to be concerned also about increased dryness in some of the patients with richly pigmented skin. The stratum corneum can be more prone to irritation and cheilitis, so really emphasizing good moisturization, really good sun protection, all very important while on the isotretinoin therapy in patients that are richly pigmented.
Yeah, John, do you go in a little bit slower in a patient of color?
Well, I mean, I mean that's a given, but I start everybody pretty slow. I mean, I'm not. I always like to start quite gently with 10 milligram a day, 20 milligram a day for the first month, just to make sure, and then I'll double it. Sure, I'll double. Like if there's no major rebound, no major worsening, I'll double it. But that's another concern, is that in patients that are maybe a risk of post-inflammatory pigment changes, you could actually, if they get a major flare-up or worsening, that could leave sometimes more scars than they had before starting the isotretinoin. So that's definitely a consideration and a good reason to start low.
Yeah, and again, you were talking about because starting even mild to moderate people on it, knowing that they get the post-inflammatory hyperpigmentation from acne, not necessarily from the isotretinoin, but also in terms of they tend to get more keto reactions, particularly Afro-Americans. And so again, you might decide if you're seeing scarring of keloidal type to actually treat those people earlier with isotretinoin to make sure that they don't get a lot more scars, because as you well know, it's difficult to treat those scars in those people once they've occurred.
So on that thought, when is it safe to start scar treatment?
Dr. Kraft?
Oh, so this is something where where Dr. Lind, I mean, it takes time for the stratum corneum to repair. When you're on isotretinoin therapy, there's impaired function there so that it's more delicate. So any type of procedure, even something as simple as plucking the eyebrows or waxing, could cause much more significant abrasion, erosion of the skin than when you're not on isotretinoin. So yeah, that's another important counseling tip, is patients should avoid doing any of these kind of procedures, even plucking or waxing while they're on isotretinoin therapy. So you want to mention that right up front. After stopping, the stratum corneum could be prone to poor healing for months after finishing. So therefore, in the past, we've often said wait 6 months before doing any kind of laser therapy. And maybe that's too long, but it's a safe number. It's something that's very reasonable, because they've had acne for so many years. They've had these marks for so long. There's no rush to just right away after you stop, go open, start the CO2 laser. There's no need for that. Give it time, wait the 6 months, and then you can much more safely do these kind of scar therapies.
Yeah, so it's an important point. So we try to avoid any procedures while they're on the isotretinoin, even potentially taking off a nevus. I usually tell people, just taking off for cosmetic reasons, you're going to get a better cosmetic result by waiting. Do step 1, get rid of your acne. Then we'll go on to step 2, looking after your scars, etc. And we can take moles off and everything else subsequently, but not at the time where they're on active treatment like the isotretinoin. Now, obviously, if they got a melanoma, you're going to change things and to do it at that time, because the risk benefit is favor of taking off the mole. But otherwise, if it's for cosmetic reasons, particularly, delay it and then subsequently do it after you're off the isotretinoin. It's a safe way. That way you don't end up in a CMPA type of thing where there's a complaint against you for inappropriately doing something you shouldn't have done.
Well,
Roxanne?
that's all the time actually that we have together this evening, but I would like to thank Dr. Kraft and Lind for doing such a practical presentation and also busting those myths on this excellent drug that's really changed people's lives. And we'd like to thank all of you for joining us this evening. Good night, everybody.
Night. Thanks again.
Good night.
Thanks, Johnny.
Thank you.
Yeah, bye-bye.
Thanks, Dr. Lind. Thanks, Roxanne.
Bye.